It's a pleasure to be here at Salisbury University. It's a beautiful campus. I've never been here before, and I really appreciate the invitation. And I hope that you'll find this presentation informative. I've geared this really for the nursing students, but I know we have a lot of physical therapy students and others here as well. So the learning objectives, there's a lot of myths and misunderstandings about Parkinson's disease I hope to dispel today. And I'd like to keep people up to date on how do we diagnose Parkinson's disease, what are the basic treatments, and what do we tell patients regarding prognosis. So by the end of the talk, you'll be ready for a strong cup of coffee, but hopefully you'll also understand more about Parkinson's disease. So myth number one, I don't need to know much about Parkinson's disease. I'm not going to be a neurologist or geriatrician. Well, this is absolutely false, because whatever you do in your medical careers, whether it's working in an emergency room, an orthopedic office, a cardiology office, unless you're doing pediatrics, you're going to see a lot of Parkinson's disease. Parkinson's often begins in patients in their 50s and 60s. By age 70, 2 out of every 100 persons in the United States will have Parkinson's disease. So we're talking about a very common condition, a complex condition, and fortunately a condition that's also very treatable. So it behooves every physician to have familiarity, and every physical therapist and every nurse to have familiarity with this condition. So one of the first misconceptions is myth number 2. Tremor is the major symptom in Parkinson's disease, and if someone develops a tremor, they probably have Parkinson's disease. Well, it turns out that many people will develop a tremor during their lives. Many people shake, but it turns out the majority of people who have a tremor actually don't have Parkinson's disease. There are other conditions and other reasons that can cause tremor. So the two myths here is, number one, tremor doesn't always indicate Parkinson's disease, but the other myth is that tremor isn't always the major symptom in Parkinson's disease. And it's very easy to confuse a condition called essential tremor, which is even more common than Parkinson's disease, with Parkinson's disease. So what is essential tremor? Well, essential tremor has a unique type of tremor. It's what we call an action tremor. It's a tremor generally affecting the hands when the hands are doing something. So here's a nice video of a gentleman holding out his hands with what we call a postural tremor. He's holding his hands out and he's shaking. This is the type of tremor we see in this very common condition called essential tremor, but it isn't the type of tremor that we associate with Parkinson's disease. So if someone comes to your office with this type of shaking, think of essential tremor, not Parkinson's disease. The other type of tremor that we associate with essential tremor is something called a kinetic tremor. That's a tremor when you're actually doing something, like trying to bring a spoon to your mouth. So here's this nice gentleman, and you can see how his hand is shaking as he brings a spoon to his mouth. This type of kinetic tremor, this type of tremor associated with an action, such as trying to thread a needle, trying to bring a spoon to your mouth, is once again not the type of tremor we see in Parkinson's disease, but it's the type of tremor that's associated with this condition called essential tremor. So essential tremor, remember I said Parkinson's affects about 2 out of every 100 people by age 70. Essential tremor probably affects about 3 out of every 100 people by age 70. So it's even more common than Parkinson's disease. And the predominant symptom is an action tremor in your hands. Now, those of you who remembers Katharine Hepburn? We have some, okay. So remember on Golden Pond, how she was shaking, her hands were shaking and her head was shaking. And a lot of people thought she had Parkinson's disease. She was a textbook case of essential tremor. She had this action tremor of her hands. She also had a head tremor. Even her voice trembled. So these are all things that we see in essential tremor, but you virtually never see a head tremor in Parkinson's disease, and generally you don't see these action tremors. So unlike Parkinson's disease, essential tremor is you'll often get a family history. About 50 to 70% of patients who have this condition called essential tremor, if you ask them about their family history, they said, gee, my mother or my father had a similar tremor when they were in their 60s or 70s. So this is a very common condition. And the reason to not confuse this with Parkinson's disease is that essential tremor is essentially just a tremor. It doesn't affect walking or balance or some of the other things we're going to talk about with Parkinson's disease. So it's really, you're doing somebody a great disservice if you've misdiagnosed essential tremor and called Parkinson's disease. So because it's an action tremor, it's a tremor when people are moving their hands, essential tremor is usually annoying if somebody's trying to bring a cup to their mouth, drink soup with a spoon, thread a needle. applying makeup. So these are the kinds of things where you'd expect an action tremor to be annoying. Now, another thing to think of, though, if you have a patient coming to your attention who has a tremor, is to realize that there are a lot of medications that will induce tremors in patients who don't have Parkinson's disease or essential tremor. So many of you who've ever worked in a psychiatric clinic have probably seen patients on lithium and realizing that if the lithium levels get a little high, patients become very shaky, and it sort of looks like essential tremor. But there's a lot of other important medicines that are commonly used on that list. Valproic acid, amiodarone, all of these agents that people take for asthma or COPD, the so-called bronchodilators, are stimulants that can make people shake and look like they have essential tremor. And then, of course, we have drugs that block dopamine that could mimic the Parkinsonian types of tremor. And patients who are abusing or using stimulants can have tremors. So there's a whole list of medications that can cause tremor, including what's at the bottom. You see the so-called serotonin syndrome, where patients are taking large doses of medications that enhance brain serotonin levels. These can also cause tremors. So it's important to get a good medication history if you see somebody who's developed a tremor. Well, what about Parkinson's disease? So we said Parkinson's doesn't cause those tremors when you bring a cup to your mouth or hold out your hands. Parkinson's disease is associated with a different type of tremor called a rest tremor. And here's 3 nice examples of people just sort of sitting there. Their hand isn't doing anything, and you see this subtle little trembling in the thumb and the index fingers. I think the bottom picture is a beautiful example. Somebody just sitting in the office, hand in their lap, and you see how it's shaking. This type of rest tremor is the type of tremor you'll see in Parkinson's disease. The interesting thing about Parkinson's disease is it's often highly asymmetric, that most patients with Parkinsonian tremors have it much more noticeable on one side than the other. Essential tremor tends to be much more symmetrical. Now, the next video is going to show you a patient that's very unusual, and this gentleman in the far video has a very, very dramatic rest tremor. And I would say if I had 100 patients with Parkinson's, only a couple would have a tremor that bad. This type of severe tremor is really the exception and not the rule in Parkinson's disease. In fact, for most patients with Parkinson's disease, tremor is a source of some embarrassment perhaps, but it really isn't what's causing them the disabilities. Here's a nice gentleman with a horrible tremor at rest, but you see when he holds out his hands, he doesn't have a postural tremor. So this would be fairly typical of a severe Parkinsonian tremor. The handwriting is also very different. If you just, in fact, it's funny, I always tease patients, when you come to see the neurologist, I always like to get a specimen. But the specimen I get does not require a little bottle. It requires a pen. I get a handwriting specimen. You learn a lot by seeing patients write. So here in the upper panel, you see a patient with essential tremor who has this rather tremulous handwriting, as opposed to the lower panel, the patient with Parkinson's disease, who draws that spiral. You don't see much tremor at all, but it's just smaller. The patients with Parkinson's disease generally, this isn't 100%, but generally don't have a tremulous handwriting, but have a very small handwriting, what we call micrographia. So there's a tremendous difference between what you might see in somebody with essential tremor versus Parkinson's. But whatever the cause of tremor, whether it's caused by Parkinson's disease or caused by essential tremor or caused by medications, tremors are intensified by stress. So when somebody's upset or anxious or excited or angry or overtired, the tremors tend to be much more noticeable. And that's why tremors often intensify considerably throughout the day, because when patients are nice, relaxed, not doing much of anything, the tremors might become almost unnoticed, but when they're upset or angry or having a fight with their spouse or getting a big tax bill on tax day, this tends to intensify the tremors rather considerably. So to summarize this section, if somebody develops a tremor, people realize that shaking isn't normal, and tremor is likely to bring the patient to talk to their primary care physician or to talk to another family member. It's a symptom that brings patients to seek medical attention. But recall that tremor does not always indicate Parkinson's disease. There are other causes such as medication-induced tremor, essential tremor, and there's a whole list of other less common neurologic conditions that cause tremor. But also realize that tremor isn't necessarily a major symptom for Parkinson's disease patients at all. So this brings us to the third myth. If you don't have a tremor, you don't have Parkinson's disease. And once again, I think if I just ask a layperson, what do you know about Parkinson's disease? They say, oh, that makes you shake. And so people would thus assume that perhaps if you don't shake, that you probably don't have Parkinson's disease. Turns out that's not the case. So it really, the essence is, how does a doctor diagnose Parkinson's disease in the first place? What are the symptoms that suggest Parkinson's disease? Because it turns out Parkinson's disease is a clinical diagnosis. You can't diagnose it on a CAT scan. You can't diagnose it on an MRI scan. There's no blood test for Parkinson's disease. It's good old-fashioned real medicine where the doctor has to take a history and carefully examine a patient. So what are those symptoms that we're talking about? Well, Parkinson's is generally referred to as a movement disorder because the clinical diagnosis is based on the evaluation of how is the patient moving, and there are certain abnormalities of movement that one sees in patients with Parkinson's disease. So what are the cardinal signs of Parkinson's disease? Well, the key cardinal sign of Parkinson's disease turns out to be what in medical terms is called bradykinesia, or slowness of movement. People with Parkinson's disease often cannot move their limbs as quickly as people who don't have Parkinson's disease. And once again, this is often asymmetric. It often affects one side more than the other. So the slowness of movement is a very key important symptom of Parkinson's disease. Tremor at rest could also be a symptom of Parkinson's disease. And there's a certain stiffness on that side of the body that might have that slowness of movement or that tremor. If you just feel the muscle tone, there's a stiffness, and it's like a cogwheel, ratchety kind of stiffness. And often when you watch the patient walk, there may be some problems with their posture or their gait, and I'll show you a nice video of that in a moment. And the key, though, once again, is the motor sides are asymmetric. One side is affected more than the other. So you've all heard the old saying, if you've seen one, you've seen them all, right? But it turns out if you've seen one Parkinson's disease patient, you've seen one Parkinson's disease patient. This is a condition that is very, very heterogeneous. There are really no two cases alike. And that's really, and whenever I talk to a Parkinson's disease support group or give a lecture, I emphasize the fact that this is a condition that varies considerably from patient to patient. This isn't a cookie cutter type of situation where everybody has exactly the same symptoms. And here's pictures of several prominent people, all of whom have had Parkinson's disease, but all who've had very different forms of the illness and different problems that plague them. But we could sort of break Parkinson's disease patients into three major groups. Then probably the most common form is where patients have some degree of that tremor at rest, some degree of that bradykinesia or akinesia, that slowness, and some degree of rigidity. But there are patients who just have a prominent tremor with very little bradykinesia or rigidity, and there are definitely some patients with Parkinson's who have no tremor at all. They're just sort of rigid and slow moving. And these are the patients that often get misdiagnosed. Because a patient who comes in shaking like this can be diagnosed by the doorman at the Ritz Hotel. But it's these other subtle patients who have very little or no tremor that sort of create a little diagnostic dilemma and often get misdiagnosed with a variety of other conditions. So, and these are also the patients who often don't come to the doctor very early on because they're not shaking, they just feel like they're slowing down. So what are these patients who don't shake, what do they look like? Well, often when they do get to the doctor, they say, well, I've slowed down tremendously. But you can't get more vague than that. I mean, a lot of us feel like we're slowing down tremendously. But the Parkinson patients, because they have this slowness of movement, might have trouble getting up out of a chair. They sort of can't propel themselves up, so they may sort of fall back into the chair a couple times before they push themselves up. Once they get on their feet, and often the spouse will comment, gee, you know, my husband's shuffling a little bit. He's not picking up his feet, or he's walking slower, or he's not standing up as straight. A classic sign, and when you watch somebody with Parkinson's disease walk, is often on the side that's a little stiff and slow, they don't swing their arm. So one arm might swing and one arm doesn't swing very well. When they're turning, they have to take several small steps. one of the most perplexing problems is that sometimes this stiff, slow limb hurts. So if their arm hurts, often these patients get sent to an orthopedist who injects their shoulder, and then they see a rheumatologist who puts them on non-steroidals, and they get tested for God knows what, and often 10 different diagnoses are made before they realize this is due to Parkinson's disease. As I mentioned earlier, that small handwriting that you see here in the middle panel is just classic for Parkinson's disease. If somebody says my handwriting's gotten smaller, that's a real suggestion it's Parkinson's disease. And because the muscles are stiff and immobile, there's sometimes a change in facial expression. Sometimes the voice gets a little softer. So if you put this whole thing together, it's Parkinson's disease, but any one of those individual symptoms could be misdiagnosed and misinterpreted. So what is meant by the term masked face? If you read about Parkinson's disease, you'll see this expression, masked face. And we're not talking about Antonio Banderas in Zorro, but we're talking about what's called masked facial expression. The facial muscles themselves can become slowly, they become bradykinetic. They just don't move much, so the patient develops this expressionless appearance and sort of that blank stare. They're not blinking as much, their facial muscles are not relaxed, and the patient actually sometimes will look like they're unhappy, they're bored, depressed. It's not that, and once again, not that every Parkinson patient has this type of facial expression, but this is very typical. And in fact, I'll try to remind patients who have this expression to do some exercises to remember to smile, so they look, so they don't look sad or depressed. And of course, having this expression doesn't mean they're sad or depressed, but it gives that impression to others. What about the walking? Because this is one of the big, this is, you know, when we say, well, how do patients with Parkinson's disease, what becomes potentially disabling? It's generally not the tremor. It often has something to do with their gait and balance. And as I mentioned earlier, trouble getting up out of a chair, slowed short steps, some shuffling, not swinging the arm, turning with little steps. These are the common symptoms. And later in the disease, patients can get very severe balance problems where they sort of fall backwards and they can't pick up their feet. So let's just see a typical little video. Here's somebody who's had Parkinson's disease for several years, and you see that she's not swinging her right arm. She's taking very small steps, but it's a narrow base gait, a little bit of a stoop posture. And this would be a typical patient who's had Parkinson's disease, let's say for several years, she's able to get up and get around, but she's just sort of slow and a bit unsteady. Well, myth number 4. If you see somebody who has these so-called Parkinsonian signs and symptoms, they must have Parkinson's disease, right? No. It turns out there are many other conditions that can cause slowness of movement, stiffness, gait problems, and tremor, or different combinations. There are a whole host of things. So, of course, the most common would be Parkinson's disease, but as we'll see in a moment, there are several medications that can cause patients to look like they have Parkinson's disease, what we call medication-induced Parkinsonism. There are patients who've had some vascular disease in the brain that causes what we call vascular Parkinsonism, that usually causes gait problems. And it turns out there's a whole host of other neurodegenerative disorders that have Parkinsonian features, plus some features that aren't seen in Parkinson's disease. That's why as a group they're called the Parkinson plus syndromes. And you know, in neurologists, we get paid more if we have big long names that people don't understand. So progressive supranuclear palsy, multiple system atrophy, cortical body degeneration. There's a whole list of illnesses that sort of look like Parkinson's disease early on, but turn out to be something else. And you know, in medicine, there's no saying if you hear hoofbeats, it's probably a horse and not a zebra. Zebras are rare. It turns out these Parkinson plus degenerative disorders really, they're not nearly as common as Parkinson's, but they're not that rare. So off and on, when even a top-notch neurologist sees a new patient that looks like they have Parkinson's disease, after a few years, it often becomes obvious that maybe 10% of those patients turn out to have one of these other less common so-called Parkinson plus disorders. But the one thing I think is important for this audience to realize is the fact that there are medications, many medications on the market that block the effect of dopamine in the brain and can cause patients to have Parkinsonian signs and symptoms. And these are patients who don't actually have Parkinson's disease. And I think most of you who've done any rotations or work with psychiatry realize that some of these antipsychotic medicines, haloperidol, for example, Haldol, can cause Parkinson-like symptoms in some patients. But even some of the newer neuroleptics that were thought to be safer, like risperidone, olanzapine, ziprasidone, etc., all of the neuroleptics really, with only one or two exceptions, have a great risk of causing some Parkinsonian side effects, so-called drug-induced Parkinsonism. Some of the medicines that we use to treat nausea, such as metoclopramide and prochlorperazine, Reglan and Compazine, also block dopamine, and these drugs can also cause Parkinsonian features. So it's important, and I would say many times a year I'm referred a patient from a very good doctor to evaluate their Parkinson's disease. And when I take a history, I realize that the patient's been taking one of these medications, and if we can get them off the medication, miraculously their Parkinson's disappears. So it's important to be aware of this list when you're evaluating patients who might have Parkinson's disease. Myth number 5, Parkinson's disease is an incurable, hopeless condition. Well, this patient was in my office. He said, "Doctor, how long will I live with this condition?" And this is a question I get asked all the time. Well, you'll live to at least 75. But I already am 75. See, what did I tell you? So the answer is, of course, the only doctors who know everything are the doctors on television. But the doctors in the real world, of course, don't always know the prognosis. But what can we say? So the good news is, turns out the life expectancy of patients with Parkinson's disease is very similar to age-matched people who don't have Parkinson's disease. I think there's like a 6-month difference, if that. The only exception being, sadly, if patients also develop other conditions such as dementia, of course, that might alter things. But with appropriate therapy, people will live a long time with this disease. So it's really a life sentence, not a death sentence. Michael J. Fox put it quite well. Parkinson's disease is the gift that keeps taking. But no cure does not mean no hope. It turns out, of course, in life, many of the things we deal with on a daily basis, people don't always age like fine wine, and no cure doesn't mean no hope. And this is a slide that I actually show all of my patients, because it turns out that the mental health of the patient probably has a greater effect on quality of life than how much they shake or how quickly they walk. And I try to remind patients that pessimists and optimists will have the same illnesses, but they'll lead entirely different lives. And this applies not only to Parkinson's disease, but to cancer, heart disease, diabetes, or any other condition one can think of. And I wish I had a secret telling patients how they can become optimists, but I think when patients realize that they can be their own worst enemies by worrying too much, that is of some help, perhaps. So getting on to myth number 6, there's no particular remedy that should be recommended for every person with Parkinson's disease. Remember, it's a very heterogeneous condition. So is there any remedy that should be recommended for every patient? And the answer is yes. Exercise. Every patient should be exercising. We got all the physical therapists in the back, so we'll get to you guys. So here's Mr. Smith. He came to see me a couple years ago, and this man was a chronic couch potato. On Saturday, he watched every college football game. On Sunday, he watched every professional football game. On Monday, he watched every rerun of the college and football. This guy never exercised in his life, and he got Parkinson's symptoms. I said, "Gentlemen, sir, you have to start exercising. You've got to get into a gym, into a program. You've got to do it." He said, "Okay, doctor, I'll follow. I'll see what you say." So he came back about 2 months later, and I was thrilled. He said, "For an hour, I turned, I twisted, I bent, I stretched, I broke into a sweat." And I said, "That's phenomenal." But by the time I got into my leotard, the class was over. So it's a joke, but there's a lesson here. Exercise is an important part of the treatment regimen for everyone with Parkinson's disease, but you can't fit a round peg in a square hole. You have to find something that the patient can do and be comfortable with, something that's, you have to have realistic expectations and begin a program gradually and then build it up. And of course, as a neurologist, we always recommend combinations of aerobic exercises as well as some balance-focused exercises, balance training, Tai Chi, yoga, walking, swimming, treadmill, bicycling, dance. There's, in Baltimore, of course, we're very lucky because it's a big medical community. We have dance classes for Parkinson's disease, we have boxing classes, we have cycling classes. But as the slide said, the exercise has been shown to improve long-term outcomes, but the program has to be tailored to the patient's abilities and needs. I'm a strong believer in recommending that my patients get into exercise classes, because I know when they go to a class, they're going to show up, hopefully, and then participate in the class. Whereas if I leave patients to their own devices to exercise at home, it's sort of like the alcoholic who tells me, well, Dr. Weiss, I only drink 6 ounces a night. I usually multiply it times 3. So if somebody tells me they're exercising for an hour at home every day, I usually divide it by 3. So, that's why I like the class. I encourage classes, particularly for people like this gentleman who's just never really been accustomed to exercising. Okay, myth number 7. Medications for Parkinson's disease are dangerous and ineffective. This is a real myth. But before we get into answering the myth, it's important for you folks to have a little understanding. What are the medications for Parkinson's? How do they work? So this is a model of Parkinson's disease that turns out to not be completely accurate, but it's generally accurate in terms of trying to understand how the medications work. Back in the late 1960s, neurologists realized that there were a group of nerve cells in the brain that produced dopamine that were degenerating. There weren't as many of these cells. The brain was basically not producing dopamine, and dopamine was very important in a part of the brain called the striatum, the basal ganglia, and that part of the brain helps facilitate complex sequences of movements. So when you want to pick up your feet and walk, or when you're trying to write, or even trying to smile, that's the part of the brain that sends the signals to tell which muscles are supposed to contract, which muscles are supposed to relax, and to do so in synchrony, sort of like the conductor of a symphony orchestra. And that's the part of the brain that was lacking dopamine. And it turns out that miraculously replenishing dopamine was highly, highly effective. Now, the main medicine that's used to treat Parkinson's disease is called carbidopa-levodopa. It's been around since really since about 1970. How does it work? Well, if the brain isn't producing dopamine, one could think that, well, you could just give people dopamine by mouth. But dopamine by mouth doesn't get from the bloodstream into the brain. It doesn't cross the bloodstream, the blood-brain barrier. And not only that, if you took dopamine in the mouth, it's highly nauseating. So you would vomit, but not get any benefit. A fellow named Dr. George Coetzee realized that dopamine was produced from another amino acid called levodopa that did cross the blood-brain barrier. And levodopa was the amino acid that the brain converts to dopamine. The problem was that levodopa by mouth, there are enzymes in the gut that would convert over 90% of the levodopa in the gut to dopamine where you don't want it. So very little levodopa would actually get into the brain unless you block that enzyme in the gut. And the medicine that blocks that enzyme is called carbidopa. So carbidopa blocks the enzyme in the gut, but doesn't get into the brain because you don't want to block it in the brain. So this combination of carbidopa-levodopa was very effective in replenishing brain dopamine and allowing patients with Parkinson's to become less stiff, to move more quickly, to walk better, and to shake less. It was truly miraculous. In fact, the drug it's now a generic, but initially it was marketed as Sinemet, which was actually Latin for sans emesis, or without vomiting, because giving levodopa alone created so much dopamine in the bloodstream that people were vomiting, whereas the carbidopa-levodopa didn't have that problem. So, in fact, if those of you who've seen the movie Awakenings, it's an older movie. I highly recommend it. It's a wonderful movie about patients who received this medication, patients who had become impaired for many years, who actually didn't have Parkinson's, but had one of those Parkinson plus disorders called post-encephalitic Parkinson's. But it was miraculous. And it still is a miraculous drug. And it really changed the way doctors thought about Parkinson's disease as well as other neurologic conditions. And all patients with Parkinson's disease will show some improvement. It doesn't cure the disease. And it's sort of like insulin for diabetes. If you're a diabetic, you take your insulin, your sugar will be better, but not necessarily perfect. This doesn't make patients perfect, but patients do move more quickly, they're less stiff, their tremor generally improves to at least some extent. It's a very major benefit for most patients. Now, for those of you, particularly in nursing, look at all these different doses of carbidopa, levodopa that are available. I mean, it's enough to drive you crazy. And they all have little different combinations of how much carbidopa is in there and how much levodopa. Generally, and one size doesn't fit all. As I said, this is a very heterogeneous condition, so patients may need anywhere from just 150 milligrams of levodopa a day to, I have patients on actually up to 2,000 milligrams a day. There's a huge range. So it's important to realize that these doses aren't all the same and that you need to know what the patient is taking. You can't just substitute one for the other. Generally, we start with the 25-100 strength. The 25, once again, is that carbidopa. That blocks the enzyme to prevent the nausea. And you need about 75 milligrams to really block that enzyme, so there's no point in using that top dose called 10-100. But whatever dose and the dose is titrated. So it's sort of like introducing insulin to a diabetic. There's no standard dose. You just have to see how the patient responds and continue to build up the dose. But the medicine, of course, has side effects. Some people get queasy, some people get a little sleepy. You can have orthostatic hypotension, but generally these can be controlled or managed successfully. And it's very unusual that a patient can't tolerate the medication, particularly if it's introduced very gradually and built up slowly. But we have some do's and don'ts. Certainly, every medicine can be problematic. We do not want to over-medicate patient. So we try to find the lowest dose that works. Over-medication certainly can cause serious side effects. We have to acknowledge that. But a big problem is we don't want to under-medicate patients. If the patient isn't walking well or able to write well, we want to treat them so they can do these things better. But the doses have to be individualized. There's no one dose that's right for everybody. Now, when we're treating Parkinson patients, what's the goal? Well, it'd be wonderful if we could completely eliminate every symptom at all times. But realistically, it's sort of like if a diabetic, you just can't make their sugar perfect 100% of the time. We have to realize that we can't control every symptom 100% of the time. The goal is to really keep people functioning in the mainstream of life, because I think when we try to make things perfect, that's when we run into the risk of over-medicating patients, which can be very serious. So here's a myth that's really sort of embedded in those of you who go online to read about conditions and Google topics. You'll get a tremendous amount of misinformation. In fact, I contend that there's more false news in medicine by a factor of 10 than there is false news in politics. I mean, what you could read online will just, it's unbelievable, the false news that's out there. And this is one of the biggest pieces of false news. Carbidopa-levodopa therapy should be delayed because it's toxic or it stops working. So it turns out, as I said before, levodopa is still the most effective treatment. There's nothing medication-wise that has exceeded its benefits. And some of the other options that have been used, such as drugs called dopamine agonists, frankly, they don't work as well, and they have many more side effects than levodopa. So there's still some reason to use these other drugs, but they certainly don't replace levodopa. So where did this business come up that levodopa was toxic or it stops working? Well, as I said, there certainly are side effects, but it's not a cure. Unfortunately, those dopamine neurons that have degenerated, giving the levodopa doesn't stop them from continuing to degenerate, so the condition does slowly get worse over the years. It doesn't stop that gradual progression, but it turns out there are many symptoms that Parkinson patients can experience that aren't due to lack of dopamine. And since we're just giving a drug that's replenishing dopamine, if somebody has a symptom that's not due to lack of dopamine, one doesn't expect that symptom to get better, but that of course doesn't mean that the levodopa isn't working. That just underscores the fact that not every symptom patients get are due to lack of dopamine. And there are certain complications of levodopa therapy. Turns out after a number of years, levodopa can often help for a couple hours, and then the response sort of wanes, and then they take a dose and it waxes and wanes. So patients get what we call a fluctuating response because the drug doesn't stick around very long in the bloodstream. And patients can also get a phenomenon called dyskinesias that I'll show you a video of in a moment. But these are symptoms that will occur whether you delay starting the medication or not. These are symptoms that really are more a factor of how long the patient has had Parkinson's disease than how long they've actually been on the levodopa. So delaying therapy really doesn't make any sense because you can't save the best for later. So the poster boy for dyskinesias is Michael J. Fox. And here's a picture of Michael on television. And these very bizarre involuntary movements are not tremors. They're not caused by the Parkinson's. This is actually caused by the levodopa. And this is particularly if somebody's being over-medicated, they will develop these bizarre, the medical term is sort of choreiform movements. This is dyskinesia. Very few patients develop dyskinesias of this severity, but if you really over-medicate somebody, this can occur. The only patients who are likely to get dyskinesias of this degree of severity are the unusually young patients, the patients in their 40s. And as I said, most patients with Parkinson's don't get it till they're in their 50s, 60s, or 70s. So even though someone like Fox could be very disabled by the dyskinesias, this is not a big problem for most Parkinson patients. But the symptoms can fluctuate, where patients have periods where if the medication levels are fluctuating or too high, they will get some dyskinesias. And then if the levels get too low, the patient suddenly finds that they're not walking as well, their stiffness and shaking and slowness might come back. And this is very unpleasant because the patient often doesn't know, are they going to be functioning well, or are they going to be functioning in this sort of off state where they're not moving as well. So it's hard to make plans to lead a normal life if you don't know if you're going to be off or on. So this is a big issue. Because not only, so when the motor symptoms, when the levodopa levels are declining and patients become maybe either shakier, slower, stiffer, often there are a lot of psychiatric accompaniments to these sort of off states where patients become anxious, they even have panic attacks, they feel very dysphoric or depressed, they get pain. So this is quite a mess. Fortunately, it is treatable, but it has to be recognized. So why do these responses fluctuate? The drug, as I mentioned before, has a short half-life. It gets into the bloodstream, but it gets out within a couple hours. Early in the disease, for the first many years, the brain can store some of this levodopa so you don't notice the fluctuating symptoms. But when that storage capacity lessens, as the cell loss increases, there's less of this buffering capacity, so the symptoms can fluctuate. A big problem, however, is the fact the lower panel shows a picture of the stomach. The medicine gets absorbed into the bloodstream, not from the stomach, but downstream in the small intestine from the jejunum. So in order to get into the bloodstream, the stomach has to empty, the medication has to get to the jejunum. So there's two factors that accentuate these fluctuations. One is the stomach emptying? Well, it turns out the stomach doesn't empty at a continuous rate throughout the day. And many patients have sort of delayed gastric emptying, so the medicine doesn't get to the jejunum very quickly. And there's a big effect on meals. Remember, levodopa is an amino acid, so if you're eating a lot of protein in your diet, the other amino acids in your diet also compete. So it gets rather complicated. The next slide is I don't expect you to digest this entire slide. It's just a list of all the things we can do. Turns out there's a lot we can do to reduce these fluctuations. We move the carbidopa-levodopa doses closer together. We tell the patients to take it on an empty stomach. We might redistribute the protein in their diet. There are certain medicines that extend the half-life of the levodopa by blocking enzymes that degrade it. We might add one of those dopamine agonists. Now, everyone's heard of this deep brain stimulation surgery. There are two main indications for doing the surgery. One is for patients who are having severe fluctuations that can't be controlled medically. It turns out this operation where they put an electrode into the part of the brain, it's almost like you would look at it as a brain pacemaker. That is very helpful in reducing fluctuations. So that would be one reason why people with Parkinson's might get this operation. And And the other is, it turns out that the one thing that the deep brain stimulation does better than medication is that rare patient with horrific tremors. It turns out deep brain stimulation is a terrific treatment for the small percentage of patients who have horrific tremors. So these are just some of the options that we have when somebody starts to fluctuate. So why am I showing you all of this? Because many of you are going to be nurses. And some patients, and this isn't any particular patient, this is just a patient who's had Parkinson's maybe for many years, who's had fluctuations, and you can see how the patient is taking carbidopa-levodopa every couple hours around the clock, every 3 hours, plus some of these other medications to help the carbidopa-levodopa work longer. So this particular patient on this very difficult regimen might be doing very, very, very well. And you might be able to control the symptoms with complex combinations of medications like this. And I'm glad to say there's a newer, longer-acting carbidopa-levodopa on the market called Rytary that helps simplify this, but patients sometimes need very complicated medication regimens. And that brings us to myth number 9. Patients with Parkinson's disease receive excellent care if they need hospitalizations for an unrelated illness or medical problem. Well, fortunately, Parkinson's disease per se seldom requires hospitalization, but people with Parkinson's disease, unfortunately, like anybody else, they could have a heart attack, or they could need a knee replacement or a gallbladder surgery. So what happens to these patients in the hospital? And I'll go back to this slide. Just think if somebody is taking this schedule religiously at home, and believe it or not, there are patients who do it. They use timers. The patients are very compliant because they see how much the medicines help. So you take this type of patient and you put them in the hospital, and everything falls apart. About 70% of patients who've had Parkinson's disease for many years, who have motor fluctuations, get totally mistreated in the hospital. The medications aren't given on time. The wrong doses of carbidopa-levodopa are given. They're over-medicated, they're under-medicated, they get delirious. They're given medicines that block dopamine like Haldol inadvertently. They get immobile, there's length of stay. It's when the patient with Parkinson's disease gets into the hospital, it can be a complete mess. And of course, to avoid this, and I want to emphasize this to our nursing students, the audience, that with most medications, most there's a policy you can give the medicine within a 1 or 2 hour window. If you're giving somebody a diuretic or a blood pressure pill, it doesn't matter really if you give it at 8 o'clock or 9 o'clock. But with these fluctuating Parkinson patients, you better give that medication on time, every time, at the correct dose. That's how we prevent all these disasters in the hospital. So precise timing and dosing is important to prevent the fluctuations, and this flies in the face of everything hospitals are accustomed to do. But at my hospital, I've taught our neuro nurses, they understand how important it is, and I hope that this message, because a lot of times when I tell the nurses or the people in the hospital that when the patient needs the dose at 7 a.m., 10 a.m., and 1 p.m., that means 7 a.m., 10 a.m., and 1 p.m., and they think I'm crazy until I explain to them why this is important, and it's not just some whim of some obsessive compulsive doctor. Now, myth number 10. The motor symptoms of Parkinson's disease are all caused by the loss of dopamine neurons. Well, the loss of dopamine neurons are the cause of most of those symptoms we see when we first diagnose the patient. But when patients have had Parkinson's for many, many years, it turns out there are other parts of the brain that can be affected, and these are parts of the brain that don't use dopamine as a neurotransmitter. So things like falling backwards or retropulsion, or this business of being unable to pick up your feet because they're stuck to the floor like they're frozen, or trouble with speech and swallowing. I guess we probably have some speech and swallowing people here in the audience as well. Certainly patients who are having trouble projecting their voice or trouble with swallowing certainly need the help of a speech therapist. People who have this freezing gait and this falling backwards certainly need the help of our physical therapy colleagues for the big and loud programs, etc. So there are a whole host of symptoms that aren't due to lack of dopamine. So here's this retropulsion. Here's a normal person being pulled backward, and here's somebody with Parkinson's disease, and he goes flying backward to the next room. So this is one of those symptoms, that patients just can't catch themselves. Once again, that was the normal control, and here's the, so this is something that of course could lead to a fall if the patient is bumped or starts back. Here's another patient now with so-called gait initiation failure or freezing gait. He's just taking these short little fascinating steps. He stooped forward, and you could see how this man might be at risk of falling. So this certainly, both of these patients are patients who will definitely need to be seen by physical therapy, occupational therapy, and there are programs to help patients deal with these difficult motor problems that aren't going to necessarily respond to levodopa. So falls often occur when patients are turning, transferring, often in the bathroom where the floor is a little slippery. They can be triggered by freezing of gait. Patients might have orthostatic hypotension, but there's two factors, though, that really predispose people to falling with Parkinson's disease. Number one is if patients are distracted or multitasking. And I remind my patients, number one, both feet on the floor at all times. Don't get on a stepladder. Don't change light bulbs. And when you're walking, let's avoid conversations or distractions. Don't carry big, heavy purses and packages. Concentrate on walking. But the last one is, unfortunately, the biggest trigger of falling is that some patients just have poor judgment. They're just impulsive. They're just not exerting due caution. Because I have patients who have really terrible balance, who never fall, and I have patients who have mildly impaired balance, who fall all the time, and it has more to do with impulsivity and lack of caution. And sometimes that's, unfortunately for some patients who are getting some cognitive decline, that certainly increases the ante as far as the risk of falling. So myth number 11, Parkinson's disease is just a movement disorder. Well, remember, we diagnose Parkinson's disease based on the abnormal movements, the stiffness, the slowness, the stooped posture, the tremor, but it turns out that's just the tip of the iceberg, because there are clearly non-motor symptoms that are very, very prevalent in patients with Parkinson's disease, including some neuropsychiatric problems, problems with autonomic dysfunction, sleep disorders. Just to quickly go through these, there's a very high incidence of depression and anxiety, often occurring together, maybe affecting as many as 50% of patients with Parkinson's disease. Anxiety disorders, mood disorders, and this can occur at any stage of the Parkinson's disease. Sometimes even before the patient's diagnosed, the family notices that their loved one is getting more depressed or more anxious. Patients can develop apathy, which is sort of a lack of motivation, a lack of interest, and a lack of concern. They're not happy, they're not unhappy, they're just disinterested and lack of concern. Very frustrating. Years into the illness, some patients will develop, I think we all of us forget a name and slow down our thought processes. This is probably a little more noticeable if somebody has Parkinson's, but most Parkinson patients remain quite competent. Sadly, though, some really develop a significant dementia. Some actually can develop hallucinations and psychosis. It's fortunately only a small percentage, but you can imagine how devastating that can be when it occurs. And sadly, our medications sometimes make these factors worse. And I know I've shown this slide at other talks. And remember the old movie, The Good, the Bad, and the Ugly. The good thing, when you upregulate the dopaminergic system, you make people move better. The bad is, well, they might develop dyskinesias or fluctuations, but if you really over-medicate patients who've been on Parkinson medicine for a long time, you could actually make a patient psychotic and make patients develop these impulsive disorders where they can't refrain from gambling or hypersexuality or spending money. You can make people pretty crazy if you don't use the medicines judiciously. And certainly hallucinations are common in people with Parkinson's disease. They're usually not horrific problems. Patients may see little shadows or have little illusions where they look at a fire plug and it looks like a person, and they blink twice and they realize it's a fire plug. So it's not a big deal, but it's important to ask patients with Parkinson's if they're having hallucinatory experiences, because that sort of tells you maybe you're on the edge, getting close to over-medicating them, or maybe they're at risk for developing more significant symptoms going forward. So it doesn't mean it's the end of the world, but it's something that I think a good examination should question whether patients are experiencing these phenomena. When I talked about autonomic dysfunction, patients often have trouble with blood pressure control. So when they sit down, their pressure may be normal, and they stand up and their pressure drops 40 points. Important once again for all the nursing students here to realize that somebody with Parkinson's disease should be checked routinely for orthostatic hypotension, because it's not unusual. I'll see a patient in the office and their sitting blood pressure is 110/60. I say, gee, that's terrific for somebody 63 years old. And they stand up and their pressure is 70/40. And they may not have symptoms yet. So you want to diagnose that. Constipation, sexual dysfunction, bladder issues are potential problems as well. And there's a lot of sleep disturbances that are associated with Parkinson's disease. Being too sleepy during the day, not sleeping well at night, post-sleep confusional disorders. Just out of curiosity, anybody here heard of REM sleep behavioral disorder? Wow, you're in for a treat. Okay, we'll get to that in a moment. But it turns out the quality of life in somebody who's had Parkinson's disease for 15 or 20 years, turns out it's more dependent on the management of some of these behavioral and emotional aspects, some of these non-motor symptoms, than the motor symptoms. So managing the behavioral and psychiatric aspects is more likely to have a great impact on the quality of life of the patient. We shouldn't be neglecting this. So this might come to as a surprise to you. Myth number 12, motor symptoms are the first signs of Parkinson's disease. Well, remember, the motor symptoms are how we diagnose Parkinson's disease, but it turns out they're not the first signs. So this is a video of a gentleman who's in a sleep lab. This was actually taken back in the 1980s. He's hooked up those wires. He's hooked up to an EEG machine, so we know he's in deep sleep. Remember, the deepest stage of sleep where you dream is called REM sleep, rapid eye movement sleep. During deep sleep, you're dreaming, your eyes are closed, but the eyes are actually moving back and forth. You're following what you're dreaming about, but your limbs are perfectly motionless. Why are they motionless? Because signals are sent from the brainstem to the spinal cord that inhibit motion. So during normal REM sleep, you're perfectly motionless. In REM sleep behavioral disorder, those nerve impulses from the midbrain to the spinal cord are not occurring. So if a patient's having a vivid nightmare, all of a sudden, instead of lying there quietly motionless, they're acting out their dream. And this guy is clearly having some kind of horrible dream. You can see he's ready to punch. Thank God his wife isn't there. It turns out that there are symptoms that occur years prior to the motor symptoms of Parkinson's disease. Years before there's any rigidity, years before there's any tremor, years before there's any gait disturbance. And one of those symptoms, and perhaps the most important, is REM sleep behavioral disorder. If somebody in the Middle Ages gets REM sleep behavioral disorder, it doesn't happen every night. It might happen, you don't have a horrible dream every night. But if somebody, let's say in their 50s, develops REM sleep behavioral disorder, there's about a 75% chance that over the next decade, they're going to start showing signs of Parkinson's disease. Another symptom that often precedes Parkinson's disease is the loss of sense of smell. Now, there's a lot of reasons why people lose their sense of smell. So if any of you has a loss of sense of smell, I don't want you to think you might have Parkinson's disease, but if you really interview people with Parkinson's disease, most will say, gee, I haven't smelled anything for years. Constipation often precedes it by a number of years, but then again, constipation is a rather ubiquitous symptom. And there's something called cardiac sympathetic denervation that I don't really have time to get into, but it's sort of a research phenomenon, not something that really affects cardiac function per se. But the key is all of these precede Parkinson's by years. So of what import is that? Well, let's go to myth 13. Research has made little progress. We have no clue about what causes Parkinson's or how to prevent it. Well, that's sort of true. There have been all sorts of studies. The goal of Parkinson research has been to try to find something that can either prevent it or slow down the progression. And these are just a list of things that have been tried in hundreds and hundreds of patients with great initial enthusiasm, things that just haven't worked. Coenzyme Q10, antioxidants, creatine, uric acid. These have all, unfortunately, there was some good research behind these that maybe they would help, but they haven't helped. just looking at statistically, it turns out statistically, smokers and people who drink several cups of caffeinated coffee a day statistically have a lower risk of getting Parkinson's disease. But I do not encourage smoking. If you enjoy caffeine, be my guest. But this is just, so nobody knows, is this cause and effect? Is this some kind of guilt by association? But it's interesting. It turns out that also having higher levels of uric acid or gout and having higher blood pressures also decreases the risk. But so there's clearly things that affect the risk. But here's where that REM sleep behavior disorder and loss of sense of smell comes in interesting. Turns out there's a whole host of genes that don't cause Parkinson's disease, but affect the risk of Parkinson's disease. And there are at least 30 different genes have been identified that might give you a little higher risk, or some genes that actually might give you a little lower risk of Parkinson's disease. So your genetic profile does play a role, but this whole pre-Parkinson syndrome suggests that something is spreading from the lower part of the brainstem and perhaps from the olfactory nerves into the brain, rather than this being a disease that begins with those dopamine neurons. And it turns out that there's a protein that's very ubiquitous in the brain called alpha-synuclein. Remember, proteins have a three-dimensional shape. It's sort of like origami. If you change the shape, you can make something that's very healthy, you can make it very toxic. And the thought is that this ubiquitous protein called alpha-synuclein misfolds and actually may be spreading up from the brainstem into the substantia nigra and all throughout the brain, and that this is actually what leads to patients developing Parkinson's. So this has led to all sorts of new insights. If we could either prevent proteins from misfolding or prevent misfolded proteins from spreading, this might actually be a way of either preventing or slowing down progression of Parkinson's. So I really think we're onto something very new in the last few years, and hopefully this won't be the next dose of false news, but it's very exciting for Parkinson's disease research. So with that, I'm going to conclude with the hope that in the near future we will knock out Parkinson's disease. But right now it's time for questions, and those of you who like that coffee story can get your cup of coffee, but I'll be glad to entertain some questions. Thank you very much.